So gave a talk yesterday, and I said that one of the challenges we have in healthcare is that we don't know what patients really want, and that as healthcare professionals, we actually are pretty arrogant about thinking we know. And we are arrogant about that because we're not only professionals, but also because we are patients, right? So therefore, we must know because we're in healthcare and we're also patients, so what's not to know? But the reality is we don't. And here's a study that was done in the United States 2 years ago where they interviewed presidents and chief nursing officers and chief operating officers on what were the most important things to improve the patient experience. And they said, new facilities, quiet time for rest, private rooms, food on demand, interactive bedside computers. My favorite was eliminating visiting hours. Now, what was striking about this is they didn't ask the most important people. They didn't ask any patients. And when you listen to patients, you get a very different perspective. So we've been very successful in my organization. On our HCAHPS scores, just to give you an example, we went from the 14th percentile of the 6,000 hospitals in the United States that are reporting to the government to the 80th percentile. For physician communication, we went from the 13th percentile to the 16th percentile of all hospitals. Now, I will tell you, I say that not to say, oh, look how great we are. I say that just to illustrate that you can improve, because when I first started this 5 years ago, I thought some of these metrics were impossible, especially with physicians. But you can improve, and it's very much still a journey for us because our goal is the 90th percentile. But we've made significant improvement, and my partner in patient experience is Kelly Hancock, who's our chief nursing officer. And we do a lot of extra work to try and figure out the voice of the patient. And so we've done 2 studies in Cleveland, one where we took the HCAHPS survey and we administered it just like the government, just like we have to do for the government. But we hired a company out of New York to go back and ask the patients exactly why they answered the way they did for every question. And then we hired a company out of Chicago to sit on one of our worst floors and do what's called ethnographic research, where they observe staff and observe patients and watch how they interact. So they had one quantitative study and one qualitative study. And we put that together, and what we found was that, first of all, patients want more respect. Now, imagine mine and Kelly's chagrin as we're sitting in a conference room getting debriefed on the studies, and the researchers put up the word respect. Kelly and I look at each other, and I said, we just spent $250,000 on 2 studies to tell us patients want more respect. We're so fired. I kid you not. But it wasn't just about respect. What it was that patients want to be treated as individuals. We typically lose sight of the fact that people come to the hospital and they get depersonalized. They don't want us to depersonalize them. They want us to know that they have spouses and families and kids and hobbies and a life. And they want that for several reasons. Number one, because they think we will care more. Number 2, they think we will be more concerned about their safety. And ultimately, the point about the respect issue is that patients want us to treat them like family members because they feel we'll care more and we'll be more careful if we're treating them like family members. They want us to communicate better, and they don't just want me to communicate better with them or the nurse. They want the nurse and the doctor to talk to each other. And this is fascinating because patients are unsophisticated healthcare consumers. Now, patient advocates will say, no, patients are very smart, and they are, but they're not sophisticated. There's a difference. And so what patients do is they judge us based on things they understand. So if I walk into a patient's room at 7 o'clock in the morning and I tell them something and then I leave and the nurse comes in at 10 and the patient asks the nurse, what did Dr. Merlino say, or what's the plan, and the nurse doesn't know, the patient looks at that nurse and says, well, if the doctor and the nurse can't even talk to each other, how can they deliver high quality care at the hospital? That's a proxy measure. We've talked about that for decades, about how patients judge us, but there's really been a lot of work to demonstrate that. But patients are constantly looking for proxies, and by the way, so are their families. Patients' families come into a room, and if they see it's cluttered, they think the hospital is dirty. So they're constantly evaluating us against things that they do understand. They want happy people, and this was interesting because, as I said yesterday, there it was, patient experience is all about making people happy, right? Well, it's actually not. What they don't want is inconsistency. So if I walk into a room and I appear angry, patients are going to look at me and ask me less questions or not engage because they don't want to make me more angry. If a nurse walks into a room and is rushed, patients are not going to engage because they don't want to hold the nurse up thinking that they're going to make the nurse angry. So they want us to be consistent, because if you're thinking about it, sitting in that hospital bed all day, all you're thinking about is what's going on relative to your position. So they're judging us on verbal and visual cues relative to their position. We also looked at patient emotions. So being a patient is extremely stressful. There's incredible anxiety. If you've been a patient or have a family member with a terrible disease, you know there's fear and terror. Think about it. You're at home on a Sunday playing with your kids. You have a pain in your stomach. On Monday, you call your doctor. On Tuesday, you see her. On Wednesday, she gets an x-ray of your abdomen. On Thursday, she calls you back to the office to tell you that there's a mass in your pancreas. On Thursday night, you're at home on the internet trying to decide how long you're going to live, whether or not you're going to see your kids grow up. Everyone in this room knows they won't. But that's all they think about. That's fear, and that is terror. Your whole life has gone through a new normal. There's incredible uncertainty and confusion, and healthcare providers, especially doctors, make that worse every single day because we do not communicate very well, and every emotion that the patient experiences, the family experiences also. So when we started thinking about improving at the Cleveland Clinic, my boss, our CEO, Dr. Toby Cosgrove, coined this model of patients first. Now, he did this because he wanted to start creating this focus in the organization. And we had an incredible burning platform because when we started this, of all the hospitals in the United States, we were in the lowest percentiles for patient satisfaction. We weren't doing well in safety. And here you have a top hospital that's listed on all the lists that are important that we care about, yet patients were coming to us and then leaving very, very unhappy. In fact, Toby used to go around giving talks saying that people came to us for high quality, but they didn't like us very much, and it was absolutely true. And what he wanted to do was create a burning platform purpose for the people that come to work every day. And his point was that, if you come to the Cleveland Clinic to work, it doesn't matter what you do. It doesn't matter that you're a doctor or a nurse or a maintenance person or a valet. You're there for patients, because that's what we do. We deliver care for patients. And by the way, it's not just about the doctor. It's not just about the nurse. It is about everybody, because healthcare today requires us to have high-performing teams of people working together. It's no longer an individual sport where one person's important and everybody else isn't. And that is the typical model with physicians and everybody else. Today, healthcare is about high-performing teams of people working together because medical delivery is very complex and it requires teams of people. So the purpose of Patients First was to create that alignment of why we exist. The other thing we did, or are doing, is making it very clear that patient experience is not about making people happy. It is about how you deliver safe care, high-quality care, in an environment where patients and families are satisfied to ultimately drive value in everything else we do in healthcare. Now, why is this important? So everybody here, I think, is familiar with HCAHPS. So think about this. The HCAHPS survey, as it's administered and required in the United States, has 9 questions that relate to how providers communicate to patients. 3 for physicians, 3 for nurses, and 3 around new medication. Now, if the HCAHPS survey were about making people happy or measuring happiness, certainly we wouldn't need to ask them 9 questions about how we communicate. But when we improve how nurses communicate at the bedside, medication errors go down, falls go down, pressure ulcers go down, and those are safety issues. When physicians communicate with patients more effectively, compliance with treatment goes up. When they communicate better with families, compliance goes up. When physicians communicate and coordinate care better with nurses, quality of care improves. Those are obviously quality issues. There's nobody that can argue that when we communicate better, patients aren't more satisfied, right? So the point is that when you direct best practices to hospitals that deliver on safety, quality, and satisfaction, you drive effectiveness and efficiency of care and better value, and that's the point. So it is not about making patients happy, it is about how we deliver what we do. And that's the whole purpose that Medicare in my country has rolled this out, because we spend hours and tremendous resources learning how to practice better medicine, but we spend very little resources thinking about how to deliver that medicine more effectively in a much more value-conscious state. And that's where we need to get better, because when we drive efficiency and effectiveness, we improve things like safety and quality. So they are linked. It is not about satisfaction or making people happy. You have to be able to execute. Everybody says, of course, the patient experience is important. Of course, improving safety is important. But how do you fix it? My mentor at Harvard Business School told me that if I couldn't figure that out, then I might as well quit, because what's the point? So the way we think about it is that healthcare is full of these silos, and our responsibility is to get them to link together. It's taking what we do from a vertical perspective and it's turning it on its side so we understand how we connect next to what the other person is doing to create seamlessness. And if you think about it, it's about driving better process and tactics. It's about aligning our people, our culture, and it's about impacting patients with engagement, activation, partnership, whatever word you want to use to bring patients better into the fold. So if you think about, this model, processes and tactics come in two forms. Number one, it's the things we do every day that hospitals are required to do, and it's figuring out what we have to fix, because a lot of hospital processes are broken. And then it's asking the question, what processes or tactics can we add on to improve what we're already doing? So we can't just do a lot of workarounds and add new things on when we have things that are broken in the hospital. We need to find those and fix those first. Aligning the culture is probably the most important thing that we've done to affect change. And what I tell people is that culture is not about change, it's about development. Now, everybody's in the audience saying, well, they mean the same thing, right? But they really are different. So if I walk into a room full of doctors and say, we're going to change you because something's not working, they're going to throw things at me. But if I walk into the room and say, look, we have a problem, and our problem is that we don't communicate well with patients, and the data shows that, we need to talk about where we need to get to. And we're going to take where we are, the culture that for 92 years has made us very successful, and we're going to ask the question, what do we need to develop, and how do we need to evolve to get to the culture we need to be successful in the future? So that's a very different discussion than using a baseball bat to say you're bad and we're going to change you. It's all about nuanced discussion with key stakeholders. You know, somebody once told me that healthcare is very tribal. You have very big stakeholder groups that are extremely powerful. And if you think about it, it's absolutely true. The doctors are a huge tribe, very powerful. Nurses, huge stakeholder, very powerful. Administration, everybody else. You have to engage each one of them together, certainly to get to the idea of high-performing teams, but you have to figure out what drives development and evolution in each particular stakeholder group, because they each respond to something different. We extensively implemented what's called service excellence, something that is very unique to hospitals in the United States. We thought they just come to us because we're great and they need us, and we don't have to treat them well. But the reality is we need to have a better way to interact with patients, so we created a program where we taught 43,000 people in our organization how to interact with patients, including the doctors. And we taught everybody in the organization how to apologize, because healthcare is full of mistakes. Unfortunately, most of them are not bad, but there are a lot of things that cause a lot of pain and suffering. And so we wanted to teach everyone how to manage that, because patients, remember, in the hospital are a captive, and there's a lot of things that happen to them. The other thing that we're doing is we're investing heavily in this concept of how do we create partnerships. Now, a speaker that was with me yesterday had a great slide that showed there's all types of different terms for describing how we work with patients, and I thought it was actually a brilliant slide. You know, we've talked about educating them, engaging them, empowering them, activating them. I like the term partnership because ultimately we need people to help us be better. Imagine if every family member coming to visit their loved one in the hospital understood that healthcare providers not washing their hands causes infection. So that when a healthcare provider walks in the room, if they don't wash their hands, the family member stops them and says, wait a minute, you did not wash your hands, don't touch my loved one. Imagine if every patient, before they receive the medication, if they're able, ask the nurse, what is that medication for? What does it do? What are the side effects? And then the nurse responded by telling them what it is, what it does, and what the side effects were. So imagine if we were able to develop platforms to better educate patients around their disease, and not only about their disease, because we do that okay, but about what it means to be a patient. Nobody talks about the fact that you're coming into a hospital, you're going to have a roommate. You're coming into the hospital, it's going to be really noisy. Or my favorite one, when doctors tell patients, don't worry, you're not going to have any pain when I do this surgery. Right? So it's how we have these conversations, and it's how we bring them into the fold, because back to the comment that healthcare today is very complex, we need patients to be our partners, we need them to help us. So it is about changing the relationship. It's going from information asymmetry to information symmetry, where patients have access to what belongs to them to begin with, which is the electronic health record and everything in it. So it's giving them that tool to access it and use it and help them understand how to use it. It's going from passive recipient of information to an active partner, where they're engaging us, where they're challenging us. As a resident, I used to walk into a patient's room and I hated when patients asked a lot of questions. It's like, I got 50 patients to see in 30 minutes, don't ask me any questions. But you know what? That makes us better. We should demand that patients ask us questions, because it prevents us from forgetting things. We have to move from this model of paternalism to participation. It's not just about us telling patients and families things. We have to make sure they're participating, and we have to do things to make sure they understand, like ask them to repeat back what we told them so we know they understand. Because just when they say, yes, I understand, doesn't mean they understand. And we need to get away from this idea of patient, physician to consumer and healthcare team. Now, I know in Canada, choice is not as great as it is in the United States, but in the United States, healthcare providers are being driven by this model of consumerism, because the government wants consumers to have more choice, because they know that by giving consumers more choice, it will make the providers focus more on what's important, like safety. And we have to get to this concept where it's not about the doctors. It is about the healthcare team. No one is more important than anybody else on the healthcare team. And I know physicians hate when I say that. Unfortunately, there aren't too many here, but but a physician in my office, in my practice, once told me, Jim, physicians are the engines of healthcare. Yes, that may be true, but when have you seen a plane fly without wings? So the point is that, I said that to him, he didn't like it, but the point is that we really have to engage everybody. Everybody is important, nobody is more important. People are different, but everybody is important. And our responsibility is to think about healthcare around this 360. It's not just the episode, it is about what happens before the episode and what happens after they leave the episode. That's systems thinking, and that's how we're going to make healthcare better. And when you think about the idea of engagement and activation and responsibility of patients versus providers, Think about it this way. There's things that happen between providers and patients, all types of things, millions of interactions. Our responsibility is to figure out which ones are important during the episode, which ones are important pre and post episode. And if you break it down, it's about educating doctors and nurses and others how to better engage patients and their families. It's giving them tactics and skills to be more successful at that. It's teaching patients and families, giving them better education. It's driving responsible behavior. It's understanding the social determinants that drive healthcare, because we have this belief in our minds that we can just put an app on a smartphone and that's going to drive patient engagement. It is not. We have to figure out the psychology of what patients think, how they think, and how they react in their environment before we can ever drive meaningful activation and engagement strategies. And then it's how you manage those touch points. There's your electronic digital solution, but it's only a piece of it. And then ultimately it's identifying which key touch points are important, because we cannot engage along every step of the continuum. We simply cannot. We don't have the resources. We have to figure out what steps along the continuum are the most important. So it is about the culture development, deciding what the interaction tactic needs to be, how we impact family and patient behavior, the social determinants of healthcare, and where do we need to have that impact. And ultimately, I think it's also about driving expectations. But what are reasonable expectations? Are they private rooms, a quiet environment? How long patients should stay? Should patients expect to stay as long as they want? How do we educate them? What is the patient's responsibility? How do they understand their care? And what's their personal responsibility? And we did several studies at my organization where we asked the question, can we impact expectations? And so every HCAHPS domain, we came up with a digital module and a paper booklet so that people come into the hospital and we have conversations with them about how to ask questions about medication, what the call light means. And for every HCAHPS domain, we pushed improvement near the 90th percentile in the study group, which is green. And here's an example. So when you do focus groups on patients about what the call light means, they think it's essentially a nurse pop-up response system. They think that if you hit that button, that nurse should be there instantly. Now, I don't know how it is up here, but I can tell you in Cleveland, it's not like that. But when you ask patients why they get angry, what they tell you is they don't actually get angry, they get anxious. And then what they tell you is, well, if I hit that call light and nobody came when I needed something small, what happens when I hit that call light when I can't breathe and nobody comes? That's their anxiousness. But when you tell patients, look, if you hit that call light and it's an emergency, people are going to come running into your room. But if you hit that call light and it's not an emergency, you might have to wait because the nurse is helping somebody else. They're okay with that because you set the expectation. You told them what it means. You took away from their anxiety. So remember, they are judging us based on their perception of the experience. And so if we fail to take into account ways to help engage them, educate them, activate them, again, your word of choice, we miss something because they're going to walk into a healthcare environment completely unprepared for anything they've ever experienced before. So finally, we must incorporate what's important to patients, and we must take the time to hear the voice of the patient. There's lots of ways to do that. The HCAHPS survey, personally, I think is very good at that. We've driven a lot of improvements by using HCAHPS data. But we have to get over the belief that we know what patients want, because we don't always know what they want. Success will come from us understanding the pieces that drive engagement. It's not just about an app. It's not just about an educational offering. It is about teaching our people how to be better. It is about engaging the psychology and the social determinants of the patient and their family. And then there's everything in between that monitors and manages those connections. And it's important because as we assume risk in my country, but also as we better manage patients to deliver more effective and efficient care, they must be engaged and activated. We have to make them partners to help us. Because when they're our partner, we will be better at what we do, and healthcare will be better overall. Thank you very much.